All right, ladies and gentlemen, this is Chapter 7, Perinatal Infections. It's interesting, many obstetrical perinatal infections are contagious, and you can see here, looks like both the male and the female got it. We will start with Group B beta hemolytic strep, Group B streptococci. Here's our case. And I want you to notice these cases. I wrote these cases specifically to bring and incorporate in the key elements that you should know for the Step 2 exam. And this patient particularly incorporates the risk factors for Group B strep. A 20-year-old gravid 2 para 1 is admitted to the birthing unit at 35 weeks in active labor at 6 centimeters dilated. The first thing I want you to notice, she is preterm. One of the risk factors for Group B strep sepsis of the newborn is prematurity. Her prenatal course, first trimester, positive Group B strep urine culture. A second risk factor for Group B strep neonatal sepsis is positive maternal Group B strep urine culture. Her first baby was hospitalized for 10 days after delivery for Group B strep pneumonia, previous baby that was affected. This woman is very high risk for her current baby to get neonatal sepsis. Group B strep sepsis is a big concern because there's 50% mortality. Now, 30% of normal women of reproductive age will have in their vaginas Group B streptococcus. This is not an infection, this is a colonization. This is important to realize because just because you get a positive Group B strep vaginal culture, it does not mean that you treat it. And I think that we have a long ways to go in realizing that the presence of bacteria does not mean infection. And we have overused antibiotics, I think, in our country, and with the result of many resistant organisms. So do not treat a positive GBS culture in the mom. All right, if a mom has GBS in her lower genital tract, what is the transmission rate to the neonate? 50%. Are these babies infected? No, they are not infected. This is colonization, not infection, and that's an important distinction. Okay, the attack rate for Group B strep sepsis in the neonate is what we're really concerned about with, and that is far less common, 0.2%. That is 2 per 1,000 babies. Now, why are we so concerned about it? The reason is the mortality rate with early onset Group B strep sepsis is 50%. Half of these babies will die. And that is too many. And that's why we go through all of the efforts that we do to prevent it. Clinical findings of early onset Group B strep sepsis is pneumonia. Here we have the case. We have a woman who has a normal prenatal course. She has no complications. She comes in labor, normal fetal heart rate tracing. Baby's delivered without any problems. APGAR scores are 8 and 9. However, within a couple of hours of birth, bash, the baby crashes. And you get a chest x-ray, and what do you see? Whiteout. Total whiteout. Do these babies get fever? No. What they do is they get hypotension. And half of these babies will die. Pneumonia and sepsis is the findings with early onset Group B strep sepsis. How do we prevent it? The antibiotic of choice is penicillin G. And remember, we are prophylacting these patients. Okay, let's move on. Newborn sepsis, within hours of birth, bilateral diffuse pneumonia, your most likely diagnosis, Group B strep neonatal sepsis. All right, what are we going to do to prevent this? We're going to give penicillin, and Group B strep is exquisitely susceptible to penicillin G. We're going to divide the patients that we're going to give prophylaxis, the moms in labor, into 3 groups. The first group, we're going to give prophylaxis without screening. We're not going to do the 36-week vaginal cultures. Why? Because the risk is so high, we're going to go ahead and give prophylaxis anyway. If she had a positive urine group B strep culture, anytime during the pregnancy, or if she had a previous baby with neonatal sepsis. And remember the case that we just went over? This mom had a previous affected baby, so she will get prophylaxis without screening. Most of the patients that we see are going to have a 3rd trimester vaginal culture. And remember, this is not a cervical culture, this is a vaginal culture. If it is positive, we will give prophylaxis to the mom in labor. If it is negative, we will not. What if a patient comes in without any prenatal care, has never had a 3rd trimester vaginal culture? Then we will prophylax based upon risk factors. And those are, if she is preterm, less than 37 weeks gestation, if the mom has ruptured membranes for 18 hours or more, or if mom has intrapartum fever, then we will give penicillin G prophylaxis. So these will be the criteria on which we will give prophylaxis of penicillin G in labor to the baby. This article looks at how rapidly the colony count of group B strep drops after giving 5 million units of pen G in labor. Within 2 hours, 80% reduction. Within 6 hours, 99% reduction in the group B strep colony count. So very, very effective. This looks at the prevalence of group B strep sepsis over time from when the initial recommendations were made. You can see that we start out with about 1 to 2 per 1,000 infection rate, and we end up with about 0.5%. So we've reduced the incidence of group B strep sepsis by 2/3. Very effective. There is now development of a group B strep rapid test, which uses a DNA probe, which can then within a matter of minutes, if not an hour, give you the results. And this can be very helpful, particularly if you have absence of prenatal care. And that's the end of our section on group B strep. Our next section on perinatal infections is toxoplasmosis. Toxoplasmosis is a parasitic infection, and it is carried by the cat. This happens to be Buggy. Buggy is my wife's cat. I don't particularly like Buggy, but that's a whole different story. And the only reason I have her picture here is because it is the contact with the feces of cats which is resulting in the toxoplasmosis infections in the United States. Here's our case, and it is a classical description. A 26-year-old prima gravida was admitted at 39 weeks in active labor at 6 centimeters dilation. She's at term. During her 2nd trimester, she experienced a mononucleosis-like syndrome. Now, what's mononucleosis-like syndrome? Perhaps a little aching, a little low-grade fever, nothing major. What do you think it probably is? Well, you think it's probably just the flu. Don't think too much of that. Interestingly, the fundal growth of the uterus lagged behind that which you would expect on a 1st trimester ultrasound. So we know how far along she is, and the fundal growth was not what it should be. Ultrasound showed symmetrical IUGR. Remember, symmetrical IUGR is associated with aneuploidy, early 1st trimester infections, and gross anatomic anomalies. She delivered a 2,250 gram male neonate. Now, small for gestational age is less than 2,500 grams. So at term, this baby is clearly small for gestational age, IUGR, with, notice, microcephaly, intracranial calcifications, and chorioretinitis. When you see symmetrical IUGR, intracranial calcifications, chorioretinitis, your diagnosis is toxoplasmosis. How is it transmitted? infected cat feces. Now, cats are clean animals. It's not petting the cat. It is handling the cat feces. Now, in European countries, particularly France, it is transmitted by raw goat milk, unpasteurized goat milk, undercooked meat. Sushi, not a problem. Cat feces in the United States. When is the time of vertical transmission? Vertical transmission means from the mom to the baby. And the time is when you have the primary parasitemia. Now, emia means bloodstream. The initial infection, the primary infection, the parasite gets into the mother's bloodstream. It infects the placenta, causes a velitis of the placenta, and crosses and then infects the fetus. The residual effect, lifelong latency or lifelong immunity. Lifelong immunity. If you're healthy and you have a good immune system, you will only get the infection once. The antibodies that you have will protect you from a recurrent infection. So if a woman has IgG antibodies against toxoplasmosis, she is protected during that pregnancy from any risk to her fetus. Lifelong immunity. And here we have a mom with her cat. It's the cat feces that we're concerned about. The lifespan, it goes in and out of the cat, and the humans are just a passive part of the system. What trimester is fetal infection the most lethal? In the first trimester. And yet, when do most toxoplasmosis infections occur? In the third trimester. How do we prevent it? Avoid contact with cat feces. Remember, first trimester, not good. And yet most occur in the third trimester. Most third trimester infections end up to be subclinical, asymptomatic. IgG antibodies will be positive, IgM antibodies positive, but you'll see no other stigmata. When you get the IUGR, intracranial calcifications, the chorioretinitis, it is usually from an early pregnancy infection. The treatment, pyrimethamine and sulfadiazine. Now, I must give you a confessional. I have never diagnosed a patient with toxoplasmosis in pregnancy. It is very rare, because most of the time it is a subclinical mononucleosis type of infection, and this is simply what I've gotten from the books. It is very uncommon, toxoplasmosis in the United States. However, the risk of fetal infection, first trimester, only 15%. Second trimester, 25%. Third trimester is the highest. But the severest in terms of bad news is first trimester. If you would remember, on the exam, you have a case of a newborn with chorioretinitis. Your diagnosis, congenital toxoplasmosis. Chorioretinitis, intracranial calcifications, symmetrical IUGR, that's congenital toxo. Now, many of these perinatal infections, you will notice, love the central nervous system. And intracranial calcifications are seen with many of these. And yet the most prominent cause is going to be toxoplasmosis. Here is chorioretinitis. This is looking at the fundus of the eye. Here we have periventricular hemorrhage and calcifications. Again, we have the periventricular calcifications. This one is very prominent on a CT scan. Here we have fetal intracranial calcifications, which are on a ultrasound. Again, severe fetal intracranial calcifications. When you see that, you should think toxoplasmosis. You can have even an obstructive hydrocephalus, and here you have enlargement of the lateral ventricles in the fetus. This fetus is infected, resulting in ascites, and you can see the acidic fluid. This is the liver on a transverse section of the abdomen. And this placenta is really thickened from intrauterine toxoplasmosis. This is one of the saddest cases I've ever seen. Look at the head. Above the orbits, there's basically no brain. Severe microcephaly from toxoplasmosis. the outcome of this baby is going to be so poor, and something which could be prevented. What percentage of women of reproductive age are IgG toxoplasmosis positive? About 40%. So most women have had exposure, and 40% already have antibodies. And that's the end of toxoplasmosis. Next, we move to varicella. Varicella is a DNA virus. It initially causes what we know as chickenpox. It results in lifelong latency. It travels to the dorsal root ganglion in the spinal column, and then can come out years and years later in the form of herpes zoster. Here's our case, and it is a classic case. Notice the details. A 29-year-old woman, gravid to Para 1, is at 34 weeks. She's preterm. She complains of uterine contractions every 5 minutes. Over the last few days, she has developed diffuse pruritic vesicles. When you think of vesicles, and she has a fever and malaise, you think of a herpetic type of infection. Vesicles, now they're not genital vesicles. These are on her chest and breasts. This is consistent with varicella. How is varicella transmitted? Is it by cat feces? No. It is by respiratory droplets. And it's estimated that probably 3 per 1,000 pregnancies may be exposed to that. Is the residual effect a lifelong latency or a lifelong immunity? And it's important to remember this is lifelong latency. Once you've got it and the virus is in your dorsal root ganglion, it's going to be there for the rest of your life. The highest risk of fetal infection is 5 days antepartum to 2 days postpartum. There is something about labor and about the time of labor when the risk of fetal infection is the highest. And in the case that we had, she was 34 weeks. She was having contractions. We'd like to keep this fetus from delivering. The maternal complication that could lead to maternal death is pneumonia. And if you get varicella pneumonia and you're pregnant, that's not a good thing. How can we prevent varicella infections? If she has had no antibodies and she is susceptible, varicella zoster immune globulin can be given and prevent infection if it's given within 96 hours of exposure. Fairly pricey, about $700, but that is a low amount when you consider what it can prevent. Now, if she's not pregnant, you can give a immunization, and the trade name for this is Varivax. It is, however, not advised during pregnancy because it is an attenuated live virus. Anytime you have a live virus, you'd like to avoid that during pregnancy. If there is varicella pneumonia, management is IV acyclovir. And acyclovir has a long history of safety during pregnancy. What happens with varicella is very similar to what happens in herpes. With the infection, where does it go? From herpes and varicella, it goes to the dorsal root ganglion, and there it sets up housekeeping. And then at intervals, or if there is appropriate stimulation, out it comes, and it will typically appear in the same site where it was obtained in the first place. So, lifelong latency. Here you have the vesicles of herpes zoster. Here we have some more of the, not of zoster, of varicella. This child has a significant case, and yet if it occurs during childhood, it's usually not a big problem. You can see in the mouth even with this child. Here we have skin vesicles which have now blistered. This is a woman who actually died from varicella pneumonia. When you look at this chest x-ray, atypical pneumonia, very poor, distinct heart border, and you can see it's all over the place. Not a good thing to have. Here's another, diffuse pneumonia. It can come back in the form of varicella, and here's a child, a zoster, herpes zoster, and you can see here. And notice the dermatome distribution, very common with herpes zoster. This is an advertisement for Varivax, a varicella live vaccine. Women contemplating pregnancy should know their risk to both mother and fetus. Pregnant women with chickenpox may experience pneumonia, we talked about that, premature labor or premature delivery. Fetal risks include birth defects of the limbs, skin, eyes, and brain. And this is particularly if it occurs early in the pregnancy. Chickenpox can be severe or even fatal in newborns of mothers who acquire the infection from 5 days before to 2 days after delivery. So it's in that period of time around labor and delivery when the risk is the highest of transmission to the newborn. Varivax. Zigzag skin lesions is skin scarring, which can happen if you have the infection early in the pregnancy. If you see on the exam zigzag skin lesions, think congenital varicella, early infection. Zigzag skin lesions, microphthalmia, this is small eyes, extremity hypoplasia. Now, when do the extremities develop? Extremities usually develop around 8 to 9 weeks. If you have an early infection, you can have reduction of the limb buds and extremity hypoplasia. What percentage of women who are of reproductive age are seropositive for varicella? 90%. So this is a small pool of women who would be susceptible. Most women already have the antibodies. And that is the end of the varicella section. Our next topic is rubella. Rubella is an RNA virus. It results in German measles. Here's our case, and it's a classic case. 18-year-old gravida 1 is 30 weeks gestation, is employed in a child care center. If you would like to get infectious diseases, then you just work in a child care center. And the kids love to bring you all kinds of infections from home. One of the children developed a rash that was diagnosed as rubella. The patient's rubella IgG titer is negative. Now, she's 30 weeks gestation. What is the chance that her fetus will get infected? We're going to answer that in just a few minutes. So, rubella IgG negative, child exposed, which developed rubella. What's the likelihood that this baby's going to get it? Rubella, mode of transmission. The mode of transmission is the same as varicella, which is respiratory droplets. It's coughing and sneezing of someone who is infected. This is not from sexual transmission. This is not from toilet seats. This is respiratory droplets. When is the time of vertical transmission? It's going to be very similar to that of toxoplasmosis at the time of the primary infection. But this is a virus, not a parasite. So the primary viremia, the rubella infects the placental villi. It travels then through the placenta, through the bloodstream, and infects the fetus. The residual effect of a primary rubella infection is lifelong immunity, which means that once you have the IgG antibodies, you are not going to have a recurrence infection. So that's why we check patients on the first prenatal visit. If they have IgG antibodies against rubella, then she is safe and her fetus will not get infected. The trimester of highest fetal infection is going to be in the first trimester. Now, what was the trimester that was the highest rate of infection with toxoplasmosis? Third trimester. In rubella, it is the first trimester. What are the neonatal sequelae of rubella? Now, this is an important exam question. The most common finding is deafness, congenital deafness with congenital rubella, followed by heart disease, followed by cataracts. And I'll show you a picture of that. Now, rubella is very rare in the United States because of the immunity. So you're not going to see a lot of deafness. But when you look at the most common manifestation of congenital rubella, it will be deafness. Prevention, give the vaccination, attenuated live virus vaccine. We don't want to give it during pregnancy. We'll give it in the postpartum period. Often we'll give it right in the hospital. And we recommend to the patient to avoid pregnancy for 1 month. This picture shows very clearly, although tragically, neonatal cataracts. Neonatal cataracts. Now, the doctor who initially discovered this was an Australian ophthalmologist who noticed a number of children brought to him with cataracts. And instead of just saying, well, I guess these kids have cataracts, he asked the question, why? And he went back and checked the prenatal course of these women who gave birth to these babies and found that they all had primary rubella. And it was as a result of those studies that the worldwide effort at immunization against rubella was initiated. Because rubella in a child is a very benign disease. Treatment of primary rubella. Is there any treatment? Any antiviral agents? There is none. There is no treatment for primary rubella. Now, what is interesting is, and this is looking at the 1 month wait to get pregnant after rubella. It used to be 3 months, but now it's only 1 month. This, I think, is interesting and exciting. This is a report from the Center for Disease Control. Rubella has been eliminated in the United States. Rubella, a virus that once caused tens of thousands of birth defects and deaths in a single outbreak, has been eliminated from the United States. In 2004, which was the last year what they reported, there were 9 cases, only 9 cases of rubella in the United States, and all of those originated from outside the United States. And yet we cannot let down our guard. We must maintain the immunization. But this is why you're going to see very few children with congenital rubella syndrome, because there have been no cases reported in the United States. The risk of fetal infection with rubella, first trimester 90%, second trimester 5%, third trimester less than 1%. So in this case that we had of this woman who was 30 weeks gestation, the likelihood of her baby getting it is extremely low. If you see congenital deafness, you should think congenital rubella, particularly if there is a blueberry muffin rash. Now, I've never seen this because we don't see it very common, but that is seen with congenital rubella. And here is an example of what that blueberry muffin rash looks like. Here's another child who has this. This arises from extramedullary hematopoiesis. You can see here the rash which goes with the rubella. Congenital deafness, congenital cataracts, congenital heart disease, think congenital rubella. What percentage of women of reproductive years are rubella IgG positive? 85%. And of course, a lot of this is because of the measles, mumps, rubella immunization, which is pretty standard in the United States. That is the end of our section on rubella. Okay, our next topic is cytomegalovirus, also known as CMV. This is a DNA virus. It is a sexually transmitted disease, as you will see as we go on. It is the most common cause of congenital deafness. Now, we talked about congenital deafness as being part of the congenital rubella syndrome. The prevalence of congenital rubella is so low that it is not a significant part of the overall causes. But CMV is very, very prevalent. And here's our case. A 31-year-old neonatal ICU nurse. Now, neonatal ICU nurses are exposed to all kinds of perinatal infections. And one of those is CMV. Now, she had just undergone an uncomplicated spontaneous vaginal delivery of a term baby that weighed 2,300 grams. Term babies should be over 2,500 grams. 2,300 grams, this is clearly small for gestational age. This is IUGR. A term 2,300 gram female neonate with a diffuse petechial rash. Newborn, SGA, IUGR with petechiae, you better think CMV. At 12 weeks gestation, she experienced a flu-like syndrome. This sounds very much like toxoplasmosis, a flu-like syndrome. Now, she had right upper quadrant pain. My suspicion is if you would have obtained some liver function tests, you may very well have seen some elevated liver enzymes because she probably had a CMV hepatitis. Serial obstetrical ultrasounds showed the fetal growth was only the 5th percentile. So this is clearly a small for gestational age baby, but I want you to particularly notice petechiae. Now this is the CMV inclusion body that you would see on histology. Cyto, cell, megalo, large cell. Look at this huge cell here. This was initially thought to be a fungal infection, and then subsequently it was found to be a viral infection. This is your CMV. How is it transmitted? It is transmitted by body fluids. That would be urine, blood, saliva, vaginal fluids, semen. Cytomegalovirus is transmitted by body fluids. Residual effect, is it lifelong latency or lifelong immunity? And the tragedy is this is lifelong latency. Once you've got it, you've got it. And it can come back and you can have a recurrence. Now, the transplacental infection rate between a primary infection and a recurrent infection is significant. If there is a primary infection, 50% transplacental infection to the fetus. If it is a recurrence, it's only 1%. Now, how can you explain this huge distinction? It's actually very similar to herpes. The primary herpes transmission rate to the fetus is 50%. And of a recurrence is only 5%. And probably this accounted for by, number one, the viral load is much higher with a primary infection. And secondly, is that you probably have with a recurrent disease IgG antibodies which can cross over the placenta and can provide protection of the fetus. The most common congenital viral infection is CMV. 1% of newborns. Now remember, there were 4 million births in the United States per year. What number of those 4 million babies have congenital CMV? 40,000. 40,000. That's a lot. I also want you to remember, if you have a newborn with petechiae, you should think CMV. Good board question. Neonate with petechiae, CMV. Now, prevention of CMV is universal precautions. And that's true whether we're looking at CMV, we're looking at HIV, or any of the body fluid-borne infections. So, who's going to give it to you? It's going to be the patient who you're not aware of. It's going to be the one who you think is probably okay. We should use protection, glove, double glove. I double glove with all my surgeries. Eye protection and appropriate coverings. So universal precautions to prevent CMV. The treatment, ganciclovir, and that has remained the same for many years. The treatment for CMV, but I must confess, I have never diagnosed a known case of primary CMV because it often presents as a flu-like syndrome. The risk of fetal infection from CMV, regardless of the trimester, is high, 50%. Now this is with a primary infection, 50%. So that's pretty high. Remember, if you would, neonatal petechiae, CMV. Neonatal petechiae Intracranial calcifications, symmetrical IUGR. Think congenital CMV. Now remember, with toxoplasmosis, it was chorioretinitis, intracranial calcifications, symmetrical IUGR. So both of these have common findings, but the petechiae is specific for CMV. What percentage of women of reproductive age are IgG CMV seropositive? 50%. 50%. So half of women are CMV positive. Now I should say that the IgG is evidence of a previous infection, and you don't know what the duration is. Typically, the first antibody to go up is your IgM. Typically that goes up, stays up for a week, maybe a month or two, and then goes down. With CMV, the IgM can go up and stay up for up to 2 years. And that makes it very frustrating when you get antibodies, IgG and IgM antibodies, to be able to say, is this a recent infection or is it a distant infection? And that brings us to the end of CMV, cytomegalovirus. Okay, our next section that we're going to go over is herpes simplex, perinatal infections. This is a DNA virus. This is a sexually transmitted disease typically associated with genital herpes. Most of these cases are herpes virus 2, although there can be genital herpes from herpes virus 1. This is a brochure from the CDC, Center for Disease Control. And what is the age of this young woman that's on here? Young women. And we're going to go over this a number of times before we're done, is that sexually transmitted diseases are twice as common among young people than older women. This looks at the estimated number of new cases of STDs, and I just want to put things in perspective. The most common is HPV, human papillomavirus. That's the most common viral. The second most common is trichomoniasis. This is parasitic. The third most common, and the most common bacterial, is chlamydia, and here is herpes. Herpes is the fourth in terms of prevalence. So we have HPV, trichomoniasis, chlamydia, and then herpes. And my suspicion is it's on the rise. Let's look at our case. A 21-year-old multipra was admitted at 39 weeks gestation in active labor at 6 centimeters dilated. Bag of waters is intact. She has a history of genital herpes prior to the pregnancy, so she has a previous history. Her last outbreak was 8 weeks ago, and she now complains of vaginal lesions. And when you examine her, on exam, she does have a localized, painful ulcerative lesion on her right vaginal wall. What is the most common cause of painful genital ulcers in the United States? Herpes. What's the most common cause of painless genital ulcers in the United States? And it is syphilis. A painful ulcer, you must think of herpes. Herpes is a sexually discriminatory disease. The prevalence is more in women than in men. It is asymptomatic more commonly in women than as men, and it is harder to diagnose in women than in men. It classically shows up as a blister, as a vesicle, and here you can see diffuse vesicles. Those vesicles will then break and they will form painful ulcers. So we start out with entry of the virus, which becomes a vesicle, which then becomes unroofed, which then becomes a painful, inflamed ulcer. You notice the female, many of the lesions are internal, and that makes it much harder to diagnose. In the male, they are external, easier to see. What is the mode of transmission? Respiratory droplets? No. Body fluids? No. mucocutaneous contact. We're looking at epithelium on epithelium. This is not toilet seats. This is not using somebody else's towel. This is genital mucocutaneous contact. Now, when we look at vertical transmission, which is from mom to the baby, what is the most likely? It is not transplacental, as it has been with many of these other diseases, like toxoplasmosis CMV. The route of vertical transmission is at contact of at delivery with a genital lesion. So if the mother has a genital ulcer and the fetus is delivered through it, that is the highest risk in terms of transmission. Residual effect of primary infection. Is it lifelong latency or is it lifelong immunity? And this is going to be lifelong latency similar to CMV. Unlike toxoplasmosis, unlike rubella, which are lifelong immunity. What happens is the virus gets through the skin, it makes its way to the dorsal root ganglia, that's where it sets up housekeeping. And it's there for life. And then at intervals, stimulated by whatever, loss of sleep, stress, or whatever, out it comes, and typically it will reappear in the same location, the same dermatome. This is an oral herpes, which typically is not associated with genital herpes. Now this picture shows a florid case of herpes. Do you think this is primary or is this recurrent? Look at the edema of the labia minora. Look at the diffuse nature of these lesions. It's not localized. This is most likely going to be a primary infection. It's going to have evidence of systemic involvement. You're going to have a fever. You're going to have probably inguinal adenopathy. This is a severe case of cervicitis from herpes. And this is what we're concerned with in terms of infecting the newborn. This baby is infected, and you can see around its mouth. This is herpes of the eye. And this baby's not doing well at all. Our big concern is that these babies can become septic and die. And this baby's going to die. Necrotizing herpes infection. How do we make the definitive diagnosis? You can't make the diagnosis by looking. It's a viral culture, which is going to be your best. Some time ago, I was on duty in the hospital, and a family practitioner called me and said, I have a patient who has a genital herpes infection. I think she needs a cesarean. She was in labor, and I went to see her. She had a previous history of herpes, she said, and she had a lesion. So I examined her. It was not an ulcerative lesion. It was not. And it was not painful. I said, I'm not convinced this is herpes. She says, I know it's herpes. I know it's herpes. How are we going to tell? Viral culture. How long will that take? That's going to take days. And here she is in labor. So what am I going to do? I did a cesarean because I could not take the chance. But you cannot exclude the diagnosis unless you have a viral culture. Now, the attack rate, this is the likelihood that the fetus and newborn will get infected. 50% with a primary infection, 5% with a recurrent. So much, much lower with a recurrent infection. But 50% is pretty high. And if the newborn gets it, what's the likelihood it's going to die? 50%. That's serious business. So if we have genital ulcers at the time of labor, management, cesarean, emergency cesarean. So I'm not convinced that this woman had herpes, but I could not take the chance because the attack rate is just unacceptable. What is the treatment? Traditionally, the treatment in pregnancy has been acyclovir. It has a track record of safety. It is an FDA category C, which means no confirmed harm in humans, but it's not as good as category B. Valacyclovir and famciclovir are newer antivirals. They are category B and probably are better because you need to give them less frequently. Valacyclovir is a prodrug of acyclovir, which gives you higher concentrations with a lower dose. On the exam, however, if you're given a choice, I would use acyclovir because it has a track record of safety. All right, let's take a patient who has a history of recurrent herpes. And she knows that she gets these recurrences about every 2 months. We know what her due date is, and we know that she's probably going to get an outbreak at about the time of her due date. We'd like to keep her from getting a cesarean. What are we going to do? We will give her prophylactic valacyclovir treatment. And this is to decrease the rate of transmission and the likelihood of requiring a cesarean. This is advertisement for valacyclovir. The trade name is Valtrex. When it's infecting him, it puts her at risk. Well, yeah, I guess it probably would. Make it simple. Let's treat it. This is a study on which this advertisement was based. This was a landmark study where they used valacyclovir, and they showed that there was a decrease in transmission of 75%. What they had was couples, one of who had herpes, the other didn't. We call that discordant couples. And the control group did not use any antiviral. The study group used valacyclovir. Now, I was surprised that the control group had only a 2.2% of transmission to a sexual partner. But what was significant was that the group that was using the valacyclovir had only a 0.5%, which is a 75% reduction. Is that significant? Yes, statistically it is. And it was published in the New England Journal of Medicine. 1 daily valacyclovir to reduce the risk of transmission of genital herpes. Now, how often are you going to have to take this? Basically, you're taking it all the time, because you're not curing the underlying disease, you're just decreasing the viral load. This is a peripheral smear, not a peripheral smear. This is a smear of the scraping of a herpes ulcer, and it is the traditional appearance of a multinucleated giant cell. Now, this is specific for herpes, but not very sensitive. In other words, you can have a false negative. If you don't see it, it doesn't mean the herpes isn't there. What percentage of women of reproductive age are herpes IgG positive? 50%. And yet, do you think 50% of women have recurrent herpes? No. And if there is any good news about herpes, genital herpes, it is that most people who get the disease and who develop antibodies do not get recurrent lesions. But once you've got it for the rest of your life. This summarizes what we've talked about with a number of these perinatal infections, and you can see how prevalent IgG antibodies are. Varicella, 90% of women will be varicella IgG positive. 85% of rubella IgG positive. Herpes, 50%. CMV, 50%. Toxoplasmosis, 40%. So very prevalent is the IgG antibodies. This is an oh my goodness slide, and it's really just a few points that I want to make. We're looking here at various clinical manifestations of congenital infections: rubella, CMV, herpes, toxo, and syphilis. And you can see there's a lot of clinical manifestations. And the main thing I want to point out is that with many of these diseases, they will have manifestations of these various clinical findings which go across the board. Meningoencephalitis, hepatosplenomegaly, jaundice, there's no particular predominance. But notice with petechiae, there's only one of these diseases that is 3+, and that is CMV. There is only one of the diseases that is 3+ for chorioretinitis, and that is toxo. There is only one which is 3+ for intracranial calcifications, and that is toxoplasmosis. So it's just to reiterate, if you see a newborn with petechiae, think CMV. If you see a newborn with chorioretinitis, think toxo. If you see a newborn with intracranial calcifications, think toxo. And that is the end of herpes simplex. All right, our next topic is HIV, human immunodeficiency virus. This is an RNA retrovirus. This is a sexually transmitted disease. Let's look at our case. A 22-year-old multigravida is a former IV drug user. There is a risk factor for HIV. Drug user, IV drug user. She was diagnosed HIV positive 12 months ago during her previous pregnancy. She underwent vaginal delivery of an infant who is also HIV positive. If we have a woman who is pregnant, HIV positive, who undergoes vaginal delivery, and who has not had any antiviral prophylaxis, the likelihood of the newborn being infected is 30%. And in fact, she had a baby HIV positive. She's now pregnant again at 15 weeks gestation. What are we going to do? This is from the World Health Organization and looks at the gathering storm. These are the number of cases of AIDS around the world. And you can see that the predominance is in sub-Saharan Africa and in South and Southeast Asia. Here's North America, much less. But sub-Saharan Africa, in some of these African countries, 30 to 40% of pregnant women are HIV positive. 30 to 40%. And the transmission rate to their babies is very high. I suspect that the next big wave is going to come from China. For many years, the Chinese government denied that there ever was a problem. Big time problems. In India currently, the Bill and Melinda Gates Foundation is giving $100 million. And it's not for treatment of HIV, it is for prevention of HIV. This figure looks at the increase in lifespan in African countries from 1955 to 1985, and you can see the lifespan was going up until about 1985 to 90, and it started going back down. Why did it start go back down? Because that latent period of HIV was now nearing its fruition, and those who were HIV positive started dying. What age group were these? Were these old people or young people? Young people in the prime of their life, dying. Notice how the lifespan went down. Now, interestingly, Uganda, it started to come back up. Why? Because in Uganda, they publicly made a crusade to educate the people about what is the mode of transmission, sexual transmission. In many countries, South Africa, for instance, Prime Minister Mbeki, for years, denied that HIV was a sexually transmitted disease. Only recently. The Prime Minister of Uganda appeared at the World AIDS Conference in Bangkok and said what they have done is to teach ABCs. A, if you're not married, be abstinent. 2, if you are married, be faithful. 3, if you can't be abstinent, and if you can't be faithful, at least use condoms. And in fact, it has worked. And I think we've got a major challenge ahead of us in prevention of AIDS. This was interesting. A Ugandan member of parliament has pledged to reward girls for their chastity by paying their university fees if they are virgins when they leave school. My goodness, how about the boys paying them? What is so tragic in some African countries, it is the folk belief that if a man is HIV positive and if he has sex with a teenage girl who is HIV negative, that he'll be cured. And when you look at the differential infection rate in adolescent girls and in adolescent boys, girls are far outweighed, far represented because of that. All right, I'm going to let the internal medicine people talk to you about the specifics of HIV infection, but I do want to talk about it in terms of pregnancy. Initially, you have a rising viral load. The CD4 count drops down. As the immune system takes over, it drives the viral load down, and the CD4 count rises. The viral load stays low for many, many years, on the average about 10 years. But gradually but surely, the CD4 count starts falling. When the CD4 count reaches about 250, the viral load will start rising. And as it rises, we start to get constitutional symptoms, opportunistic diseases, and death. Patients with HIV don't die from HIV. They die because of opportunistic diseases. The mode of HIV transmission is body fluids, similar to CMV, blood, urine, saliva, genital fluids. How is it transmitted? IV drug use, sexual transmission, perinatal. I'm going to focus on the perinatal transmission here. Residual effect, lifelong immunity or lifelong latency. And tragically, this is lifelong latency. Once you've got it, you're stuck with it. And the likelihood of survival has not been good. With the antivirals now, things are looking better, but many of these drugs have significant side effects too. The result of HIV immunosuppression is AIDS. The cause of death with HIV/AIDS is opportunistic diseases, tuberculosis, pneumocystis, toxoplasmosis, cytomegalovirus. If you're immunosuppressed, you can get systemic recurrence of CMV, and coccidiomycosis pneumonia can also become systemic. In terms of perinatal transmission, vertical transmission, it used to be thought that this was transmitted to the fetus transplacentally. And if it's transmitted across the placenta, then it really doesn't make any difference whether it's a vaginal delivery or whether it's a cesarean delivery. The studies, however, showed that when you had twins, there was a difference in the transmission rate between the twins. Now, if it was transplacental, should there be any difference? No, they should both be infected the same. But what was found was the lower twin had a higher rate of transmission than the twin that was presenting second. And it became clear that it was exposure to genital secretions that raised the likelihood of transmission. So vaginal delivery is clearly the highest risk in terms of transmission to the baby. Transplacental, less likely. Breastfeeding can occur, but it is much, much lower. And in many countries in developing countries, where there is poor nutrition, is the risk of dying from malnutrition higher than the risk of getting HIV from breastfeeding? And that becomes a public health issue. This is a chest X-ray. And if you look at this, are you happy with this chest X-ray? This is actually my chest X-ray in 1992. I live in Southern California, And I had got a little bit of a rash, I got a little low-grade fever, a little bit of pleuritic chest pain, and I wondered, what's going on? I talked to an infectious diseases friend, and he said, oh, you probably have Coxsackie, not to worry. So I didn't worry. I went home, however, and even though it was 105 degrees outside, I was feeling cold. I put on a coat, took my temperature, and I had a fever. I went back, saw a real doctor this time, took a chest x-ray, and what does this look like to you? It was read as atypical pneumonia. What's the most common cause of atypical pneumonia? Mycoplasma. How do you treat mycoplasma? Erythromycin. So I took erythromycin. Like a good patient. Hard on the gut. Did I get better? I didn't get better. Finally, I couldn't sleep laying on my back. 3 weeks later, this was my x-ray. Better or worse? Worse. Now, usually I like to go home. I don't like to stay in the hospital, but I told my wife, honey, you better take me to the hospital. I'm not doing well. My PO2 on room air was 60. Immediate bronchoscopy. Took washings and put me on IV erythromycin. Didn't get better. Spiking fevers, sweats. One day the resident came in and said, we want to get one more test on you. I said, what test is that? We want to get an HIV test. HIV? Me? HIV? And as I thought about it, why shouldn't I have HIV? Obstetrician, catching babies before they fall on the floor without gloves, cutting the umbilical cord, blood squirting all over the place. I've been exposed for years. The next 48 hours were the longest 48 hours in my life. Will my wife become a widow? Will I leave the hospital alive? That was a hard time. Well, I want to tell you, I did not have HIV. But what I did have was coccidioidomycosis pneumonia. They thought I had pneumocystis. Thank you very much. I'm doing just fine right now. This looks at the root of HIV exposure and what is the likelihood of transmission. If you are transfused with HIV-positive blood, 95% infection rate. That's pretty high. Now, what is the next highest risk? And it is mother to infant, 30% transmission if no antivirals and if vaginal delivery. And that's why perinatal transmission is so important to avoid. The current management, it is recommended that all patients be tested for HIV who are pregnant, and the recommendation is to have them sign an informed refusal rather than an informed consent. And the reason is because of the high rate of transmission to the baby. Vertical transmission rate without AZT, 30%, if AZT, less than 10%. So, we certainly want to give antivirals to the mother. Multi-drug therapy. The current recommendations by the CDC is that all women who are HIV positive should be given triple therapy, not just AZT, because they're concerned about the development of AZT resistance, particularly if they have a low CD4 count and a rising or high RNA load. So regardless of the titer, we will start all patients with triple therapy at 14 weeks gestation. The delivery route, a cesarean is offered, particularly if the plasma viral load is over 1,000. If she has an undetectable viral load, is there any benefit to the fetus? There probably is not, and I suspect in the next few years we'll be coming out with guidelines for this. What will be the neonatal HIV test if the mother is HIV positive? And you know the baby's going to be positive because of passive maternal IgG antibodies which cross the placenta. This is an article from Lancet. A surrogate was breastfeeding a baby. The baby got HIV from breastfeeding. So breastfeeding is a risk factor for transmission. This is some hopeful studies showing that gel placed intravaginally may prevent AIDS, and in many countries of the world, women are in a very precarious situation. Man demands sex, he is HIV positive. What can she do to protect herself? And this may be a possibility to help that. Everybody in the United States is recommended to get HIV testing, even the priest and even young people. That's the end of HIV, perinatal infections. Our last section on perinatal infections is hepatitis B. Hepatitis B is a DNA virus. It is sexually transmitted. Now, the most common chronic viral hepatitis is hepatitis C. The most common. And yet, it has very little relevance in terms of obstetrics and perinatal transmission. There is no treatment that we use for hepatitis C in pregnancy. But in hepatitis B, there is things we can do. Let's look at our case. A 29-year-old multigravida was found on routine prenatal lab testing to be positive hepatitis B surface antigen. She's an ICU nurse. Perinatal infections, ICU nurse. She received 2 units of packed red blood cells 2 years ago after experiencing postpartum hemorrhage with her last pregnancy. Did she get it from her ICU patients? Did she get it from the packed red blood cells that she was transfused? Not entirely clear, but she is hepatitis B surface antigen positive. This map shows the areas of the world that have high prevalence of hepatitis B. And you can see northern Canada and Alaska among the Inuit, sub-Saharan Africa, Southeast and South Asia, high rates. Some years ago, I was visiting a professor in China. And in the Chinese population, Rh negativity is only 1% of the population, compared with 15% in the United States. Hardly saw any Rh disease, but hepatitis B was rampant. It is endemic in Southeast Asia. This is a picture of a woman in a refugee camp in Laos who had hepatitis B, and she died a few weeks after this picture was taken. Very high rates in Southeast Asia. How is hepatitis B transmitted? Body fluids, similar to HIV, similar to CMV. The ways of hepatitis B transmission are similar to HIV and to CMV. IV drugs, sexual contact, perinatal. And our concern today is primarily perinatal. What are the symptoms of hepatitis B infection? Usually none. Most patients who have been exposed to hepatitis B will be carriers but will have no symptoms and no physical findings, and yet they are capable of transmitting this to their babies. The likelihood of transmission across the placenta is very low, and most of this is in the 3rd trimester. The greatest risk in terms of transmission from mom to baby is vaginal delivery, exposure of the fetus to the genital fluids in the birth canal. Yes, transplacental is possible, breast milk is possible, but primarily it is vaginal delivery. Now, looking at the number of patients who develop a chronic hepatitis and comparing adults and neonates, it is really tragic. 10% of adults will develop chronic hepatitis. 80% of newborns will develop chronic hepatitis. A high rate in the newborns, and totally unfair. The vertical transmission rate, if the mom is hepatitis B surface antigen positive only, it's 10%. But if she is hepatitis B surface antigen and E antigen, it's 80%, and the E antigen is an indicator of infectivity. So we want to check out and see if she's hepatitis B surface antigen positive, is she also E antigen positive? So we have a high rate of transmission if she is both surface antigen and E antigen positive. Now, the most likely outcome, if the mom has an acute infection, it is asymptomatic carrier, and yet she can transmit it to her baby at high rates. If the mom is hepatitis B surface antigen positive, the follow-up testing is hepatitis panel, and we're going to look for the other antigens. We're going to do liver enzymes, ALT, AST, gamma GT, look for bilirubin. If she has only surface antigen positive, if she has normal liver enzymes, and if she has a normal level of bilirubin, we will then say that she is an asymptomatic carrier, and yet she is capable of transmitting it to her sexual partners as well as to her baby. The delivery route. Well, my goodness, you'd say, since the baby gets this because of exposure to genital fluids, we should do a cesarean. No, a vaginal delivery. And the reason for this is because there is excellent ways of preventing the fetus from getting infected. Perinatal management, no scalp procedures. We do not use a scalp electrode in labor, no scalp IVs in the newborn, and all babies will get active immunization and passive immunization. The passive immunization is with hepatitis B immune globulin, H big. The active immunization will be given the first of 3 doses for the hepatitis vaccine. Management for acute hepatitis is not very good. Interferon, there are some new antivirals, but there's not a whole lot that we use in pregnancy. This is from the Center for Disease Control, and it shows since the advent of vaccination, the number of new cases of hepatitis B have dropped markedly in 20 years. Hepatitis B prevention by getting the 3 shots, and you should have received yours as a healthcare professional, and you need to make sure that you, in fact, have antibody positive. As far as the baby is concerned, at birth, it'll get the first of 3 doses of the hepatitis B vaccine, get the hepatitis B immune globulin. At 1 to 2 months of age, we'll get the 2nd dose, and at 6 months, we'll get the 3rd dose. Can I breastfeed my baby if I have hepatitis B? And the answer is yes. If your baby gets a shot called hepatitis B immune globulin and a shot of hepatitis B vaccine within 12 hours, it is okay for you to start breastfeeding your baby right away. Many HMOs now are vaccinating all babies, regardless of whether the mother is hepatitis B surface antigen positive or not. And I think that's a very cost-effective approach. In fact, many school districts are not allowing children to go past elementary school to enter into middle school without being immunized for hepatitis B. And in fact, this is the only sexually transmitted disease which can be prevented by immunization. There is now coming the Gardasil, which is the HPV, but that is not widely available yet. Hepatitis B is down among children and teens. According to the CDC, 90% drop. And that, I think, is great. All right, let's summarize what we have said before we end this section. These could be very helpful on your board exam. What should we know about group B beta strep? It is not lifelong immunity, neither is it lifelong latency, but it is lifelong colonization. It does not need to be treated in the mother. In labor, we will give Pen-G for prophylaxis to the baby and vaginal delivery. Toxoplasmosis and rubella are both lifelong immunity. Once the mother has IgG antibodies, she will never get a secondary infection unless she is immunosuppressed. The treatment for toxoplasmosis primary infection is pyrimethamine. There is no treatment for rubella, and vaginal delivery. CMV, varicella, herpes virus, HIV all have lifelong latency. Treatment for CMV, ganciclovir, vaginal delivery. Now, these really don't fit in terms of delivery. We don't do a cesarean for varicella, but for herpes virus, we will give acyclovir for treatment, and if there is an active lesion in the birth canal, cesarean delivery. For HIV, and this I think probably we need to change, we give triple therapy rather than AZT, and a cesarean is offered, particularly if she has a high viral load and a low CD4 count. In terms of the step 2 exam, what should be some terms you should remember in terms of these various infections? Toxoplasmosis, intracranial calcifications, chorioretinitis. Varicella, zigzag skin lesions. This is from early infection, first trimester, and microphthalmia, small eyes. Rubella, the most common finding, although it's very rare because we don't see rubella very much anymore, is deafness, congenital heart disease, and if we were to put a third one, it would be cataracts. CMV, remember, petechiae, hepatosplenomegaly. Syphilis, we have non-immune eye drops, macerated skin, and what is unique about herpes virus, HIV, and hepatitis B is there is no congenital syndrome with these infections at all. No syndrome at all. And that, ladies and gentlemen, is the end of hepatitis B and of our perinatal infections.